Now coming to the facial nerve, seventh cranial nerve. It is a cranial nerve number 7. It is a mixed nerve, longest interosseous course, which means within the bone it travels more. It stays longest interosseous course. Now coming to the columns, it is present in all the columns except the first and the last column. So GSE column, it is absent. SVE column, it is present because it supplies the facial muscle. Number 3, GVE column, it is present because it supplies the submandibular, sublingual, and the lacrimal gland. Now coming to the GVA, general sensation to the nasal and lacrimal region. Number 5th column is SVA, taste from anterior 2/3 of the tongue, except 2/3 of the tongue, except the circumflex papillae. Now coming to the 6th is GSA because it supplies the skin of auricle and proprioception of facial muscle. Now coming to the diagram, this is the pons, 6th cranial nerve, 7th cranial nerve winds around the 6th cranial nerve nucleus. This winding is called as internal genu. It is called as internal genu, and it comes out of the brainstem, and that is the pons at ponto medullary junction, and enters into the internal acoustic meatus. Enters the internal acoustic meatus along with the 8th cranial nerve and the labyrinthine artery. Once it comes out of the internal acoustic meatus, it will have a sharp bend, which is called as external genu. In the external genu, near the external genu, it is related to a ganglion. In the external genu, it is related to a ganglion called as geniculate ganglion. Okay, from the geniculate ganglion, in the geniculate ganglion, it gives a branch that is called as greater petrosal nerve, which comes and synapses in the PPG, that is the pterygopalatine ganglion, because the greater petrosal nerve is a parasympathetic nerve, so it does not rely in the geniculate ganglion because the geniculate ganglion is a sensory ganglion. So in the medial wall, in the middle ear, it is related to the medial wall of the middle ear. This is the middle ear. In the middle ear, this is related to the medial wall. In the medial wall, it is related to lateral semicircular canal. It is related to the lateral semicircular canal. From the medial wall, it turns down into the posterior column. This is called as G2. That is the second genu related to the posterior wall of the middle ear. And gives a branch to the stapedius muscle. It gives a branch to the stapedius muscle, and before entering into the stylomastoid foramen, it gives one more branch that is called as cauda tympani nerve. Okay, cauda tympani nerve. This cauda tympani nerve joins the lingual nerve. It joins the lingual nerve because lingual nerve enters the submandibular ganglion, but do not relay there. Submandibular ganglion does not release there, while the cauda tympani relays and joins the what? It relays and joins the lingual nerve. This is the lingual nerve. Joins the lingual nerve. Lingual nerve is the topographical connection. Once it joins, it gives a branches to the. So in the submandibular ganglion, it gives a branch to submandibular gland, and it gives a branch to the sublingual gland. Okay, and supplies the anterior. It supplies what? Anterior 2/3 of the. It supplies the anterior 2/3 of the tongue, and anterior 2/3 of the tongue. General sensation is supplied by lingual nerve from anterior 2/3 lingual nerve, anterior 2/3. Okay, and the taste, that is the special sense, is supplied by cauda tympani nerve. It is supplied by the cauda tympani nerve. Now coming to this, continuing, it enters the stylomastoid foramen. It leaves the stylomastoid foramen and divides into the two branches, anterior branch and the posterior branch, anterior branch, and it enters into the parotid gland. So it enters into the parotid gland and gives the 5 branches. It gives 5 branches, 3, 4, and 5 branches. This branch is called as temporal branch. This is the temporal branch. This is the zygomatic branch. This is the buccal branch, and this is the marginal mandibular branch, and this is the cervical branch. This cervical branch supplies the platysma muscle, and the buccal branch supplies the buccinator muscle. These 5 branches are the motor branches. Terminal. These 5 branches are the terminal motor branches. Okay, and the posterior supplies the ear external auditory canal near the external skin of external auditory canal. This is called as posterior auricular nerve. Okay, and one more branch which supplies the muscles from the posterior side. It is the posterior belly of digastric muscle. Number 2 is stylohyoid muscle. Number 3 is auricular muscles, and number 4 is occipitalis muscle. So remember this, the greater petrosal nerve. Now the lesser petrosal nerve comes from superior cervical ganglion. From the superior cervical ganglion, the sympathetic nerves form the plexus around the internal carotid artery to form internal carotid artery plexus. From these plexus arises the deep petrosal nerve and joins with the greater petrosal nerve. This is the deep petrosal nerve, and this is the postganglionic. Why? Because this comes from the sympathetic chain and supplies what? It supplies the lacrimal gland. This greater petrosal nerve and the deep petrosal nerve joins to form median nerve, also called as nerve to pterygoid canal. Nerve to pterygoid canal. The greater petrosal nerve releasing the pterygopalatine ganglion, and from there it supplies the maxillary nerve, then the lacrimal nerve, and supplies the lacrimal gland. It also supplies the nasal gland. And it also carries the taste sensation. It carries the taste from soft palate. Okay, so remember the cauda tympani nerve. The cauda tympani nerve, which is there, it is a mixed nerve. Cauda tympani nerve is a mixed nerve. Why? Because it is supplying the glands, that is the submandibular gland and the ligament, which are the secretory motor, and it also has a sensory supply to the anterior two-third of the tongue. Now coming to the next part is the posterior belly of digastric and the stylohyoid are very much similar because their insertion is because they run parallel to each other and attached to the hyoid bone, and they have both nerve supply. Both of them have the same nerve supply and facial nerve, and both of them helps in elevation of the hyoid muscle. The similarities are more. Only difference is that remember it is attached to the temporal bone mastoid process. It is attached to the mastoid notch. It is attached to the mastoid process, but it is attached to what? Styloid process of temporal bone. It is mastoid process of temporal bone. It is a styloid process of the temporal bone. Its origin is from. Okay, attachment is similar. It is attached to the hyoid bone. Now coming to the one more point you have to remember, the anterior wall of the middle ear is called as carotid wall because the carotid artery is related to internal carotid artery. The deeper petrosal nerve arises from the internal carotid artery. This deep petrosal nerve arises from the internal carotid artery, which forms the network of sympathetic fibers around the internal carotid artery. It carries the sympathetic fibers originating from the superior cervical ganglion. Okay, from the superior cervical ganglion. And remember, the greater petrosal nerve does not rely in the geniculate ganglion. It does not rely in the geniculate ganglion. It is a preganglionic parasympathetic nerve fibers. While as the deep petrosal nerve is a postganglionic sympathetic fibers. The greater petrosal nerve and the deep petrosal nerve together forms what? This forms a median nerve or a pterygoid nerve to pterygoid canal. And one more thing here, I told you it enters into the parotid gland. In the parotid gland, the seventh cranial nerve does not pierce the parotid gland. It does not pierce the parotid gland. Instead, if this is a superficial part of the parotid and it is a deep part of the parotid, this is the deeper part of the parotid, the facial nerve travels in the patis faciovenous. It travels in patis faciovenous. Facio means facial nerve, and venous is nothing but retromandibular vein, because the retromandibular vein and the facial vein travels in this plane without piercing the parotid gland. Now coming to the most common nerve injury in parotid surgery. In parotid surgery is buccal nerve injury. There will be buccal nerve injury. Most common nerve injury in case of submandibular gland surgery. Submandibular gland surgery is marginal mandibular nerve. Now coming to, let's just discuss about the secretomotor pathway of lacrimal gland. Now coming to the secretomotor pathway of lacrimal gland, it originates from the superior salivating nucleus. It is carried by seventh cranial nerve. It goes to the greater petrosal nerve. From there it goes to the pterygopalatine ganglion where they relay, and it goes to the maxillary nerve. Then it goes to the zygomatico. It goes to the zygomatico temporal nerve. From there it goes to the lacrimal nerve. From there it goes to the lacrimal gland. Finally it supplies the lacrimal gland. Now coming to the injuries. Injury to the lingual nerve. Coming to the injuries, remember the injury can happen in the three places. Number A, only to the cauda tympani nerve. Number B is only to the lingual nerve. Number C is what? Both cauda tympani and the lingual nerve. So A is only to the cauda tympani. Then what will happen? Loss of anterior two-third of the tongue. Taste sensation will be lost, and loss of salivation because it is supplying what? Salivation because it supplies submandibular gland and sublingual gland. Now coming to the B is only the lingual nerve, only to the damage to the lingual nerve before joining cauda tympani. Then what will happen? There will be loss of general sensation from anterior two-third of tongue. Now coming to the in the C, region C is lingual nerve injury in the lower part of infratemporal fossa then the feature of 1A plus B will be present after joining. It means after joining the cauda tympani nerve. Now coming to the lesions in the face. Now if you think upper motor neuron and the lower motor neuron, upper motor neuron lesion versus the lower motor neuron lesion in 7 cranial nerve. Okay, so if this is the motor cortex, this is the motor cortex, this is the motor cortex, and this is the facial, and this is the facial nerve nucleus, and this is the face discipline. This is the face. Okay, okay, face discipline. So remember, lower half of the face is indicating with red, lower half of the face is indicated with red, and upper half of the face is indicated with blue. Upper half of the face is indicated with blue. Remember, the upper half of the face is having bilateral innervation, both the side. Upper half of the face will have innervation from both the sides. Same way, upper half of the face is having innervation from the both the side. Okay, but the innervation to the lower half of the face happens from contralateral nucleus, from the contralateral nucleus. Okay, so any lesion, any lesion in upper half of the face will lead to what? In the upper, so upper motor neuron lesion will lead to what? Contralateral lower half face paralysis. Contralateral lower half face paralysis. A lesion on the lower motor neuron lesion, LMN lesion will lead to ipsilateral facial paralysis. Ipsilateral facial paralysis. Okay, this is important. Ipsilateral and contralateral. Now coming to the next part is the injuries to the nerve. So coming to the injuries, now let us discuss about the injuries. Now let us discuss about the injuries. Injury to the 7th cranial nerve. So let us case 1. Whenever there is a damage, whenever there is a injury before it enters into the stylomastoid foramen. This is number 1 case. So what will happen before it enters? This leads to what? Ipsilateral facial paralysis. It leads to ipsilateral facial paralysis. So case 2, what will happen? Whenever there is a injury at before giving the cauda tympani branch, that is at this level. This is 1. This is 2. So what will happen at the 2 level? So it leads to what? Loss of taste from anterior two-third of the tongue, plus loss of salivation from submandibular gland plus sublingual gland. Now coming to the case 3 is remember this is along with case 1 in the case 2. In case 3, the lesion is where before giving the stapedius muscle, before giving the stapedic nerve to stapedius muscle, so somewhere in the middle ear. So what will happen? The lesions, what will happen? So here A plus case 1 plus case 2, both the symptoms of case 1 and case 2 plus hyperacusis. Now coming to the case 4. So case 1 plus case 2 plus case 3. So what and all the symptoms are present in. So this one case 2 remember has case 2 plus case 3 remember has case 2 plus hyperacusis. So case 4 remember case 3 plus what? Loss of lacrimation and plus loss of taste from soft palate. So remember the lesion here will be at this level. So lesion somewhere here. This is case 3, this is case 4. Okay. So remember in case 1 what is happening? This is gone. So muscles of facial expression are damaged. Facial expression is damaged in case 1. In case 2 along with that this is also damaged. Case 1 plus what? Loss of salivation plus loss of taste sensation from anterior two-third of the tongue. And in case 3 what is happened? Case 2 plus hyperacusis. Okay. In case 4, case 3 plus what? Loss of lacrimation and taste sensation from soft palate.